So this topic is about postpartum hemorrhage, but before we talk about postpartum hemorrhage, I just want to review some pharmacology because they usually ask what's the mechanism of action for a few drugs that we use. So there is mainly two types, right? So we know we always use oxytocin, and oxytocin is for uterine contraction, right? So the pathway is a GQ receptor pathway. It will cleave the phospholipase C with the help of phospholipase C, IP3 to DAG. IP3 releases calcium from ER. Calcium bind to calmodulin and myosin light chain, contracted smooth muscle of the uterus, and then the uterus has blood vessel parallel within the smooth muscle. So when you contract the smooth muscle, it will constrict the blood vessel. So that's how you use oxytocin for postpartum hemorrhage to stop it, right? And then terbutaline and phentoterol, those are beta agonists. It's a GS receptors. So oxytocin is GQ and terbutaline and phentanol is GS. Those are the uterine relaxation. So those are the tocolysis. So whenever you have a condition called uterine inversion, when the uterus is like prolapsing out of your vagina, you have to relax the uterus so that you can try to push it back in. So in that case, you use terbutaline, right? So those are the key two drugs that you use on the uterus. The other one is, we always heard of misoprostol, right? The misoprostol is a prostaglandin E1 analog. Misoprostol is used mainly for the abortion, right? So it ripens the cervix and expel the products of conception, and it will decrease the vascular tone. And there's two types of prostaglandin you can use to stop bleeding, right? So the prostaglandin has so many types. There's the E1, which is misoprostol, which you use for the ripening the cervix and expel the abortive products. There's E2, F2, and I2. I2 has nothing to do with obstetric. So I2 is a prostacyclin, which is apoprostol, iloprostat. Those are for pulmonary hypertension because it causes vasodilation, increase in platelets aggregation. So I2, remember, has nothing to do with uterus abnormality. It's for pulmonary hypertension. E2 and F2. E2 is dinoprostone and carboprostat. You can use it to stop the postpartum bleeding. They're the second line drug after oxytocin in postpartum hemorrhage. If the oxytocin doesn't work, you can use E2, dinoprostone, F2, carboprostat. I2 again is only for pulmonary hypertension. E1, misoprostol. And there's another popular drug in obstetric, mifepristone, which is the progesterone analog. It has nothing to do with prostaglandin. Prostaglandin, E1, is misoprostol, but those two drugs are used together. So now, postpartum hemorrhage, right? So the postpartum hemorrhage, remember, 40, atony, trauma, tissue, thrombin. Most common cause is uterine atony. The definition of a postpartum hemorrhage is anytime you give birth vaginally, you lost more than 500 millimeter of blood. With C-section, you lost more than 1,000 millimeter of blood. So we have to remember the causes which are important. But let's look at the symptoms. So vaginal bleeding, soft, enlarged, bulgy uterus above the umbilicus. So anytime you have a non-contracting uterus, it has to be soft, enlarged, and above uterus. If it's rigid, placenta eruption or placenta previa, right? And the treatment, always try the non-invasive one first. So you give a fundal massage first, then you give oxytocin, IV, remember? And then carboprostate, prostaglandin F2, didanosone, E2, methylargotamine. Those can be used. Remember the argot products, it's a vasoconstrictor, so make sure you don't use that in any patient that has previously existing ischemic heart disease. So by manual massage, oxytocin. If not, then you have to look for other causes, right? So 40, trauma. Trauma, how do you look for trauma? You look for trauma with specular examination. Tissue, is it retained placenta? Most commonly, placenta accreta. You have to see, are we putting too much traction on the umbilical cord? Coagulation disorder, any kind of von Willebrand factor, eclampsia, placenta eruption. Last result, if the bleeding don't stop, then you do a hysterectomy, right? So the causes of trauma are like, these are like not that important information: C-section, vaginal canal, injury by baby, medical instrument, forceps vacuum, episiostomy, and hematoma. So anytime the patient is bleeding, the first thing you think of is uterine atony. Then, is there risk factor for trauma? Is there risk factor for tissue, retained tissue? Retained placenta, remember, it's gonna give you a rigid placenta, not soft, rigid umbilical uterus, not soft uterus. Coagulation, so knowing the risk factor will help you get the right diagnosis too. So uterine atony is the most common cause of postpartum hemorrhage. So the risk factor over any type of over distension of uterus, so like many baby, multiple pregnancy, big baby, prolonged or false full birth, muscle fatigue. Anytime the mom has a full bladder, it can cause uterine atony too. So this management will just be you put the cat for her to pass urine, retain placenta, infection, medication, any uterine relaxant, terbutaline, nifedipine, calcium channel blocker, or magnesium. So that is the uterine atony. Again, the management is by manual massage, oxytocin. Last result is hysterectomy. So I made this little comparison between uterine atony and uterine inversion because I usually get this 2 question wrong. I know that it's like easy, but this is a concept that I always get it wrong, so this figure help. So first, there's a placenta eruption, right? Anything with the rigid uterus is placenta eruption. The baby could still be in there. And then the placenta, remember the placenta previa and placenta accreta, it can also give a rigid uterus. Then atonic uterus is boggy uterus. Baby is already out. Uterine inversion, there is a mass, vaginal bleeding, and absent fundus. So these are the 2 opposite conditions. So the management is completely opposite, right? So uterine atony, we just talk about it. Massage, oxytocin, carboprostate, dinoprostone, and methylargotamine. So the uterine contraction, right? And then uterine inversion is, if you see inversion, give fluid first, you try manual replacement first, right? So you try to push it back in, but if it doesn't work, then you need to relax the uterus. So you use terbutaline, nitroglycerin, any type of uterine relaxant, you use it. The important thing is you don't try to remove the placenta before you put back the uterus. Only after you place the uterus back in, you try to place the placenta inside. And then after you place the uterus, then you try to remove the placenta And after that, if it's still bleeding, then you try the uterotonic drugs, right? So for the uterine atony, you massage the uterus to stop bleeding, and you use the medication to help the uterus contract, right? But for the uterine inversion, you manually replace, don't remove the placenta. After the uterus is back into the abdominal cavity, pelvic cavity, you remove the placenta. If it's still bleeding, you do the uterotonic drug. And then the last result is if it's still bleeding, then you try to get it, like do a hysterectomy by laparotomy. And then for me, looking at the risk factor help. So placenta erection, the risk factor are hypertension, eclampsia, preeclampsia, cocaine use, abdominal trauma, smoking, right? For uterine atony, over distension of the uterus, many babies, multiple pregnancy, big baby, the tired uterus, the placenta retained, chorioamnitis, medication like halothane, magnesium, nifedipine, terbutaline, right? So terbutaline is the uterine relaxant. Too much using uterine relaxant causes uterine atony, right? So this is a beta agonist, so it's used in asthma, I think. And then the uterine inversion, nulliparity, traction, too much traction, excessive fundal pressure, big baby, previous inversion, and placenta accreta. So postpartum hemorrhage, so many causes of postpartum hemorrhage. 40, atony, trauma, tissue, and thrombin. You have to know risk factor, symptoms management. There's another condition called uterine inversion, can cause postpartum hemorrhage too, but you will see a mass. Then you try to manually replace. That's it.